Now let us see what is hiding behind. I invite Dr. Manju Abraham, Professor and HOD, Department of Ophthalmology, Government Medical College, Ernakulam, for the talk.
A warm good morning. Uh, I'll be presenting about drugs that cause toxicity to the posterior segment of the eye. Now, loss of visual loss and toxicity may be minimal or reversible following early withdrawal of the offending agent. Rarely, it is permanent and cause progressive loss of vision. Now, based on the pattern of retinal toxicity, these medications can be grouped as those causing disruption of the retina, those causing crystalline retinopathies, vascular damage, retinal folds, cystoid macular edema, and uveitis. Now, which are the drugs that cause disruption of the RP? We have phenothiazines, chloroquine derivatives, clofazimine, steroid preparations, cisplatin, the newer chemotherapeutic agents like the MEK and the FGFR inhibitors, and antiretroviral therapy. Now, among phenothiazines, thyroidazone and chlorpromazine, they bind to the melanin in the RP and cause damage to the outer retinal layers. Toxicity is dose dependent. Thyroidazone in doses over 800 milligram and chlorpromazine over 2000 milligram per day is toxic. Fundus in the early stages may be normal or show granular pigment stippling. Later on, you can see nummular areas of RPE loss in the posterior pole, and in the late stages, you can see widespread depigmented areas alternating with hyperpigmented plaques, optic atrophy, and vascular attenuation. But despite cessation of treatment, fundus changes progress due to continued toxicity of the drug. Electrophysiological tests as well as fields are abnormal. Chloroquine derivatives we know are used to treat autoimmune diseases and malaria. Hydroxychloroquine with a better safety profile is preferred over chloroquine. Visual loss is irreversible and continues to progress. The risk factors are it is both dose and duration dependent. Patients with renal diseases and age over 60 years are at increased risk. Now, in the premaculopathy stage, the fundus shows subtle pigment stippling in the macula with loss of foveal reflex. Visual fields, SDOCT, multifocal ERG, and fundus autofluorescence help us to pick up very early stages of toxicity. If the drug is stopped at this stage, vision may return to normal. It progresses on to the bullseye maculopathy, and in the advanced stages, we have marked atrophy of the RPE, pigment clumping, optic atrophy, and attenuated vessels. Baseline screening and then annually after 5 years is required. Clofazimine, used in the treatment of dapsone-resistant leprosy and psoriasis, is toxic over 300 milligram per day, causing bullseye maculopathy. Cisplatin can cause a profound visual loss within 6 weeks of starting treatment. It may present either as an ischemic retinopathy or a macular pigmentary change or macular and optic disc edema. We know that long-term use of steroids can cause central serous retinopathy, and even intravitreal injections of triamcinolone, if given for high doses, can cause outer retinal necrosis. Now, the drugs that cause crystalline retinopathies, the important ones are tamoxifen and nitrofurantoin and canthaxanthin. Tamoxifen, usual dose is 20 milligram, but a daily dose of 180 milligram or a cumulative dose of 100 gram is toxic. Patients with high BMI and dyslipidemia are at higher risk. The fundus changes are a pseudocystic foveal cavitation resembling macular telangiectasia, intraretinal crystalline deposits between the GCL and the IPL, macular edema, and punctate pigmentary changes. SDOCT shows disruption of the outer retinal layers. Hyperreflective lesions are seen in the inner retina. Electrophysiological tests are abnormal. Screening is required at baseline and every year. Now, the drugs that affect the retinal vessels, the main ones are the aminoglycosides, the oral contraceptives, intracameral vancomycin, interferon, and rarely brolucizumab also. Now, an inadvertent injection of massive doses of aminoglycosides can cause an acute vaso-occlusive event, resulting in macular whitening, cotton wool spots, and arteriolar narrowing. The visual loss is profound. Even low doses which are thought to be safe, 100 to 400 microns, can also cause toxicity, but the picture is less severe. Oral contraceptives can cause thromboembolic complications like CRAO and CRVO, but now that the estrogen content within the pill is lesser, the chances of complications are also less. Interferons used in the treatment of hepatitis C and multiple myeloma can present about 4 or 8 weeks after initiation of treatment as an ischemic retinopathy. Vancomycin, rarely an intracameral injection, can cause hemorrhagic occlusive vasculitis within 1 week of administration. The main drugs that cause cystoid macular edema are the taxols, pioglitazone, topiramate, fingolimod, and nicotinic acid. It causes large cystic spaces in the outer retinal layers. It usually resolves with discontinuation of the drug. The drugs that cause retinal folds, these are the sulfur derivatives, acetazolamide, sulfur antibiotics, topiramate, chlorthalidone. A ciliary body swelling or a choroidal effusion causes anterior movement of the iris lens diaphragm. This can cause a vitreous traction on the macula and retinal folds. Quite a large number of drugs cause toxic optic neuropathy. It may be antibiotics like long-term use of ciprofloxacin, chloramphenicol, and linezolid, anti-malarials, anti-TB agents, anti-arrhythmic agents, anti-cancer drugs like carboplatin and methotrexate, pseudotumor cerebral picture caused by vitamin A toxicity, long-term steroids, and nalgesic acid. Even vaccines can cause demyelination of the optic nerve. Now, linezolid is an antibiotic used to treat gram-positive bacteria and multi-drug resistant TB and Mycobacterium avium infections. It is toxic over the dose of 600 milligram per day if given for more than 2 weeks. There is a bilateral fall in vision, the disc is hyperemic, and there is peripapillary nerve fiber swelling. It is, if you're planning to give for more than 28 days, check the vision and the fundus monthly. Coming to the anti-TB drugs, ethambutol, can cause bilateral loss of central vision. Fundus is normal. Field shows central scotoma, and OCT of the optic nerve head shows loss of nerve fiber layer. It is both dose and duration dependent toxic, and more in renal dysfunction and elderly patients. INH can also cause loss of vision, optic disc hyperemia, but once the drug is stopped, vision usually improves. Among the cardiac glycosides, digitalis at toxic doses can cause photopsia, xanthopsia, and form visual hallucinations. Amiodarone can cause an incidence and bilateral loss of vision. Patient complains of seeing a blue-green ring around the light. Disc is swollen. Amiodarone can also cause a picture of non-arthritic AION, but here it is acute and unilateral loss of vision. Vision usually improves once you stop the drug. Rarely it can cause an optic disc pallor. Now, to summarize, a careful and detailed medication history is needed, especially if the vision is worsening. You need to know more about the recent updates on toxicity. Retinal imaging helps us in the early detection of even subclinical cases. It is not always possible to reverse the changes, but in most cases, progression can be prevented by cessation of the drug. Thank you.
Thank you, Dr. Manju, for stacking in order such large and diverse number of posterior segment findings in short time.